Hello, everyone, and welcome to the Emergency Preparedness and Response podcast series. My name is Srinath Yadlapalli, a nephrology fellow at Indiana University School of Medicine, and I'll be your host. Today, we will talk about water quality in dialysis. We will be splitting this important discussion into two parts, and this episode will be part one. We all know that water quality is paramount for dialysis, but that standard is put to the test during a disaster. Whether it's a flood or a hurricane, compromised water creates massive challenges for both patients and providers. In today's episode, we will discuss water quality standards set by AAMI, which is the Association for Advancement of Medical Instrumentation. We will also discuss the role of biofilms and outbreaks caused by chemical intoxication. To help us navigate these complexities, we are joined by a leading expert in the field. Dr. Matthew Arduino recently retired, actually just a few days ago, as a senior advisor for environmental hygiene and environmental microbiology and infection prevention at CDC, which is the Centers for Disease Control and Prevention. He has been with CDC for more than 35 years. Dr. Arduino is a subject matter expert in environmental infection control and microbiology, dialysis associated diseases, healthcare associated infections, disinfection, sterilization, and water treatment. His career has been defined by a deep commitment to patient safety. He has authored or co-authored more than 160 articles, 14 book chapters, and 3 training manuals. His contributions have been recognized with numerous honors, including the Department of Health and Human Services Secretary Awards for Distinguished Service and the Distinguished Alumni Award for the College of Mount St. Vincent. Most notably, he is a recipient of the 2023 APIC SHEA Award, which is the Association for Professionals in Infection Control and Epidemiology, and the Society for Healthcare Epidemiology of America Award for lifetime achievement and contribution to the field of infection prevention and epidemiology. Dr. Arduino, thank you so much for joining us today.
Thank you, Dr. Yadlapalli. It's great to be here today. I'm only 3 days into retirement, and I'm still trying to figure out what to do with myself.
That's great. And let's go with the first question. As we know, Dr. Matt, the primary water source for dialysis is the local municipal drinking water supply. Hemodialysis patients are exposed to massive volumes of water, approximately 120 to 160 liters per treatment, which creates a significant risk for complications if chemical or microbial contaminants are introduced. Could you please explain the minimum water quality standards that must be maintained by dialysis units to ensure patient safety?
So, what we have for patient safety, the minimum standards are those that were developed by AAMI, and this goes back to 1982, and they've been updated since then. But from the microbial side, we saw that there were as the colony counts in the final bath reached 1,000 and above, your attack rate for pyrogenic reactions also greatly increased. And when we look at outbreaks, and then the committee decided, hey, what's the difference between 1,000 and 2,000? And when we're talking logarithmically in growth, there's no difference. So the committee got stuck with 2,000 as that. Those limits have now been lowered, and I'll explain that a little later as to why the microbial limits, and then water is a log less than the final dialysate at that time. And as for chemicals, we saw even before 1982 that there were issues related to chemicals in the drinking water. These were due to compounds like fluoride, chlorine, and chloramine, which are your drinking water disinfectants, that caused adverse events in dialysis patients. And that's just some of the water ones and that were available. So AAMI first published its first dialysis recommendations, which was hemodialysis systems RD5 in 1981. And since then, that standard has gone on through a number of revisions. And endotoxin was added primarily in water for reuse of dialyzers. And now there's endotoxin standards for both water and dialysate. And we have now, through the years, the committee again decided in 1996 to break up the standard to separate components, and the CMS conditions of coverage decided to require parts of two of those standards, which is RD61, which is water treatment systems, and the final dialysate bath RD52 2004. Those were adopted in 2008 by CMS, and ongoing from there, AAMI continued to publish and modify standards as they went on. In 1986, AAMI published the first document concerning the practice of reuse and the water quality that was required there. And that's where it was 200 CFUs, just like the water for dialysis, and an endotoxin standard was added to that. And that's where because exposure on the blood side, if bacteria and blood get into the blood compartment, endotoxin will actually bind to the membrane. And even though you reprocess that dialyzer, that endotoxin does not get removed until it sees protein again, which can cause pyrogenic reactions. So these were all adopted into the CMS regulations. So this is 42 CFR Part 494, which is the conditions for coverage for ESRD in 2008. What we require is an annual chemical analysis of your incoming water, so you know what you're dealing with and how to treat it. Monthly cultures and endotoxin testing for microbial contamination. And then later on, in about when RD52 was published, we added action limits. So instead of chasing a problem, when you reached an action limit, you would actually think about doing something preemptively before your system gets out of control. So many facilities would actually disinfect their systems based on the action limits, which were half the value of the maximum contamination limit at the time.
Thank you, Matt, for the detailed answer. It's fascinating to see the historical shift from the 1980s to the current standards we use today, and how we created a safety net with half of the maximum contaminant level for total counts and endotoxin. Now, can you tell us what is the role of biofilms within the water distribution system, and how do they specifically affect hemodialysis patients?
So microorganisms in general prefer to be growing on surfaces where they form biofilms. And a biofilm is basically a collection of organisms that attach to the surface, and then they produce an exopolymer polysaccharide to protect them, along with other products that the organisms produce. And these biofilms occur in all engineered water systems, whether it's a drinking water system, your building plumbing, your sanitary plumbing, and of course, dialysis water systems. And the presence of dead legs within a system and low flow aid in the development of biofilms. So water-associated organisms are adapted for these low nutrient environments. These biofilms form on your piping, and these or in your dialysis machine in the fluid pathways, and these are highly resistant to disinfection due to their complex mixed structure. They have a modified physiology, and again, they form this matrix as a protective measure around them. What we try to do is to prevent them from getting out of control. They're always so we want to prevent growth and amplification of these, and that's the ideal strategy, which is why we have to select the appropriate materials for construction. We have to look at your water distribution system, and make sure it's a compatible system with the disinfectant methods that you're going to use. And there are two types of systems and with dialysis water treatment systems. You have a direct system, which includes where there's no storage tank. So the system is in operation when the machines are in operation. And it's a one-way flow, typically of water to the end of the loop and drain. The problem with direct systems is that when you shut that system down, there's no movement of water or fluids within that pipe. So they sit stagnant until the next time individuals come in for treatment. Now, what we also have is indirect system is the storage tank. So your RO will produce water to fill that storage tank, and that storage tank will allow water to be recirculated through the whole distribution loop and return to the storage tank. The unused amount of water returns. And as the tank empties, it eventually triggers a float switch, which then turns the RO on to produce more water. We also have issues with how people design their systems. I've seen systems associated with hospitals where then they run a branch off their water system to another room somewhere. And that little branch that comes off or T that comes off becomes an area that causes stagnation because that becomes a dead leg. And you should really remove dead legs from these types of systems. And so there are several types of materials that are used for plumbing. These include PVC Schedule 40, PEX, Teflon, and medical grade stainless steel. I've seen very few of those. Most of the systems are either PEX or PVC because some of these materials can get quite expensive. Realize that PVC Schedule 40, if you look at a scanning electron micrograph of that surface, it is not flat. And there are little valleys and things where organisms can actually hide and set up there. As you move to Teflon and stainless steel, these surfaces become smoother. And some of these allow for heat disinfection, and some are strictly used for, you can only use chemicals to disinfect.
Thank you, Matt. Thanks for explaining the direct, indirect systems, along with the dead legs and the importance of compatible systems in dialysis units. This highlights the importance of preventing biofilms very early on,
Mm-hmm.
especially since they are so resistant to standard disinfectant treatments. Moving from the biological to the chemical side of the equation, can you give us an example of an outbreak caused by chemical intoxication associated with water quality in dialysis patients?
Yes, I can. So the first outbreak that I participated when in my early days at CDC was with a facility in Philadelphia, and they were actually dialyzing patients. And all of a sudden, they noticed that their patients were developing anemia. And when we went to look at the fluid, they had a breakthrough of chloramines in their system. And what we discovered was that their carbon beds weren't sized properly, so they weren't able to remove all the monochloramine from the water. And Philadelphia is one of these first cities that had introduced a monochloramine as a disinfectant. We also had a couple of outbreaks due to fluoride. One was due to an accident at a drinking water plant, and the dialysis facility was fairly close, where hydrofluorosilicic acid was added to add fluoride to the water, drinking water, and there was a spill, and that a good amount of that fluoride got into the water above the concentration that's usually there in drinking water. And it did cause reactions in patients. And that was early on before I even joined the CDC. And there was another outbreak in Chicago where the facility was remodeling and they were going to put in a new water treatment system. And in the process, they had a temporary system in place that used deionization to purify the water. What happened is the company that was bringing in the tanks and exchanging tanks actually changed the indicator lights at the light that would say whether the tanks were functioning well and producing good quality water or needed to be changed. And they did not inform the dialysis tech who was doing that. So he looked over and said, "Oh, the indicator light is yellow. Oh, we're still good. These tanks are still operating perfectly." Well, what happened was these tanks actually exhausted while patients were being treated. And when a DI tank exhausts, it kicks off ions with the least affinity to the resins in there to be replaced by ones that had more affinity for those ions. And so what happens when that happens is ions come off in boluses and peaks. So fluoride was one of the first things that got kicked off the resin. And we had 4 patients who developed cardiac arrest due to fluoride entering their bloodstream and having issues with calcium transport in muscles, and they died. We could also mention aluminum, though, which in the early days was also a problem, causing dialysis dementia in patients. And in drinking water, you may see increases in aluminum depending on the type of flocculant your drinking water uses. They use alum. But in the 2 outbreaks that in my career that I looked at, is the aluminum pumps were being used to pump acid. One was a facility that converted to bicarb and took their acetate storage tank and used that for acid, and it had aluminum house pump, and they were pumping that up to the dialysis floor from their basement. That pump actually corroded and came apart, and there were even flecks in the dialysis bath of parts of the pump. And this caused dialysis dementia in a number of their patients, seeing that. The other one was picked up because the facility was monitoring serum aluminum levels, and they kept scratching their head going, "Now, these are going up." But it's not because of phosphate binders, it's not because of diet. Well, why is it going up? And then they went back to their room, and the transfer pump that they were using, that had been used to transfer acid from out of the 55-gallon drums into their jugs, had broken down, and they replaced it by just going to a hardware store type of store and got another transfer pump. And this pump also contained aluminum components and was being eaten up by the acid. We've also seen issues where disinfectant is not properly rinsed out. So again, these are all in the early 90s. We had a pediatric facility that went to go disinfect their water system, and the vendor that came in actually put 30% hydrogen peroxide into their storage tank. It was a flat bottom storage tank. So it was a storage tank that could never be drained. And the outlet was about 6 inches up off the floor. And they were actually using a test kit that was inadequate to detect the peroxide that was still in the system. And they dialyzed patients and caused hemolysis. We should also caution for facilities who are associated with hospitals, find out what their water management program is doing, because some of these institutions are treating their incoming water. So they're doing supplemental disinfection, and some are using monochloramine, and they're trying to get levels at 3 milligrams to 4 milligrams in their system to control Legionella. And in Europe, there have been 2 instances where stabilized silver hydrogen peroxide was actually used, and which caused hemolysis in patients in the UK. And there was something similar that happened in Israel. Again, these were institutions that were actually adding additional disinfectant to the water to control Legionella in their distribution system, in their tap water distribution system side of the house. So it's always good to confirm what's happening if you're a hospital-based unit, to confirm whether they're doing supplemental treatment or not.
Thank you, Matt, for those detailed examples. That's one of our board questions in nephrology, wherein chloramine causes hemolysis, but I have never seen it in real life. It also tells us the importance of the deionizer in the treatment process. Thank you, Dr. Arduino, for sharing your expertise on these foundational elements. In this episode, we covered the AAMI water quality standards, the differences between direct and indirect distribution systems, and the hidden risk of biofilms and chemical intoxication. There is much more to discuss regarding how these systems hold up when a crisis actually hits. Join us for part 2 of our water quality discussion, where we will pivot to microbial outbreaks and practical strategies for managing water safety during and after a disaster. Thank you for listening.
This podcast is copyrighted by the American Society of Nephrology, all rights reserved. All content in this podcast is for informational purposes only and is not intended to be medical advice. This podcast should not be used in a medical emergency or for the diagnosis or treatment of any medical condition. Please consult your doctor or another qualified healthcare professional. If you have any questions about any medical conditions or before or taking any drug, changing your diet, or commencing or discontinuing any course of treatment. Thank you for listening to this podcast by the American Society of Nephrology.